All right, so superficial veins for the legs, the lower extremity. So for this one, we have our GSV, our greater saphenous vein, and our small saphenous vein. For upper extremity, our cephalic and basilic veins. Basilic. We have that connection between the cephalic and the basilic in the antecubital fossa. This is that median antecubital vein. And AC. Also, you guys need me to go over like where these vessels run? Or are you familiar with like, you know, their location? Like small saphenous vein is posterior calf. Also called stocking seam vein. Stocking seam. Greater saphenous is in the medial lower extremity. We know cephalic vein is lateral. And basilic vein is medial. We can even say medial to brachial veins. So if we're able to visualize those brachial veins, we're going to know that the basilic vein is medial to that. So if we're in our arm and we see a vein, artery, vein, and we're in transverse view, so we have our transverse view. Our transverse view. So this is our notch over here. So we're going to see, this is for right arm. All right. See our brachials here. And this is going to be our basilic. Or medial. So thrombosis. So in deep veins, called a DVT, deep vein thrombosis. And superficial veins, called superficial thrombophlebitis. Thrombosis of. And we have Virchow's triad. These are the three mechanisms for developing clots within the venous system. So, I mean, this holds true for both superficial and deep veins. We're going to have stasis, hypercoagulability, have trauma / vessel injury. So this is going to be trauma vessel injury. This is anything that damages endothelial layer, that inner layer of the vessel. So the main thing that we're going to have under here is going to be like IVs, lines. We can put like, central lines, PIC lines, IV central lines. Blood draws. The patients in the hospitals, they're getting labs done every hour or whatever, to monitor certain labs. They're usually nurses keep going for that same vein because, it's an easy one. They may be a hard stick. So that constant repeated puncture of that vessel is going to wind up to trauma and damage that endothelial layer. Another big one under here is going to be previous DVT. So previous DVT can leave scarring, vessel wall. So that scarring or that chronic changes to that vessel, the vessel is no longer smooth on the inside of that wall following a DVT. I mean, sometimes they don't resolve completely, and you wind up with this scarring on the inside of that vessel wall, and that irregular surface is now a nice surface for new clots to form upon. So previous DVT can fall under this category. You can also have, you know, physical trauma or injury. And then under stasis, we move to stasis. So this is anything that's going to impede blood flow or stop the blood flow from moving. Anything that will impede blood flow. So we can put compression, vessel. Actually, we're going to put proximal compression vessel. Proximal compression of vessel. So anything that can compress that vessel proximally is going to impede the blood flow. So, you know, things that could fall under that could be like a mass, tumor, can have maybe like a large hematoma. Baby. Oh, what is it? These and these. A baby. So also under stasis, we have lack of movement. These are the people that are bedbound. These are people, you know, that are intubated or sedated. So under here, we can also put venous reflux. So with venous reflux, we have blood flow coming back. And it causes the blood volume in the lower parts of the calf, particularly to become more stagnant. and hypercoagulability. So this is anything that will cause the blood or any condition that causes blood to have a higher propensity for clotting. This is going to include all your different clotting factors. So the most common clotting disorder is your factor V Leiden. Factor V Leiden. That's your most common. So other clotting disorders will include protein S and C deficiency. Antiphospholipid syndrome. Lipid syndrome. You can also have a condition called HIT. So this is heparin induced thrombocytopenia. Thrombocytopenia. So this is actually where in the hospital they're administering heparin to the patients. It could be like prophylactics just to prevent clots. And they go too far with the heparin that it can actually develop into a condition called HIT, is heparin-induced thrombocytopenia, where they then all of a sudden develop the propensity for now developing clots as a result of the reaction to the heparin. So again, under hypercoagulable, we also have cancer, particularly pancreatic. And GI cancers, like gallbladder, so GD, and stomach. Also lung cancer. Another condition that puts us in a hypercoagulable state would be surgery. Pregnancy. And with that is both pre and postpartum. I think if I left anything out.
Next to lung, under pancreatic and GI, what does this say?
Like GI cancer, so like gallbladder cancer,
Okay.
stomach cancer, esophageal cancer.
Gotcha.
Yeah, things like different GI cancers. Pancreatic's the big one though, like for whatever reason, pancreatic cancers, these patients, tend to develop clots. So this is our common femoral vein, greater saphenous vein connecting into it. You have your arteries here. So your femoral artery and deep femoral artery. So looking at this picture, is this the right leg or the left leg? Anyone want to try and guess?
The left leg, the right.
50-50. Left or right?
The right, I think.
Huh?
Yes, the right.
Right? This one's actually going to be left.
Oh.
So if we're in transverse, again, our notch is toward the patient, right? So if we have our screen, we're in transverse. This is always going to be our notch on this side. So the notch points to the patient's right. So this is now going to be medial over here. So the vein is always at the common femoral level going to be medial to the arteries, and that greater saphenous vein is going to run medial as well. So the vein is medial to artery. Have the same picture on this side now. This is our camera. So over here is going to be our notch. So the patient's right. So then now this is going to be medial. This is going to be the right leg. On this side, this is medial. So DVT. Symptoms. Well, big one is unilateral swelling. So swelling could be bilateral. So just because the patient has swelling in both legs doesn't, exclude that it could be DVT. Typically, the most common presentation is going to be unilateral swelling. But if the DVT is very extensive, particularly in the legs, and extends all the way up to the IVC, you're now blocking that blood flow as well in the other leg. So those swelling could be bilateral if DVT is extensive. To include IVC. Put under here pain, discoloration, particularly redness, pain, discoloration, redness, warmth. So we can also have shortness of breath. Tachycardic. Chest pain. So typically those three are more indicative of PE, or pulmonary embolism. Another thing too to remember, difference between pulmonary embolism and pleural effusion. So the pulmonary embolism is actually blood clot that's now within the veins of the lungs. So it goes to the heart, into the right side of the heart, pumped into the pulmonary arteries, which bring the blood from the right side of the heart into the lungs. And then kind of works its way down into the smaller vessels of the lungs. But you can have a very massive clot, within the lungs. So you can actually have thrombus filling that pulmonary artery and actually branching into both sides of the lungs. Something like that would be called a saddle embolus. So the clots don't necessarily have to be in the small veins within the lungs. You can have very large thrombus within the lungs. This becomes a very critical situation. So the clots could be very large in the lungs. So if you can imagine, you have this clot that's impeding blood flow from getting to the lungs. So that's why they wind up with shortness of breath. They're just trying to breathe harder. So under shortness of breath, we can also put tachypneic. So that means they're breathing faster. So not only are they're short of breath, they're also breathing harder and faster, trying to get more oxygen exchange because their body needs it. So their O2 stats are going to be low. They're going to be short of breath. They're going to be tachypneic. They're going to be breathing faster. Because they have lower oxygen levels, the heart is now working harder and faster to try and compensate and get more blood through the body. So that's why your heart rate starts elevating. So they're going to be tachycardic. And you can imagine too that this now potentially causes chest pain as well. Their lungs aren't getting the oxygen that they need. So you could potentially wind up with necrosis or damage to the lungs because they're not getting the oxygen, which can manifest itself as in chest pain. The reason this is such a potentially serious condition and why these DVT exams are so critical is because this can happen in an instant. A large clot that's in the leg could just potentially just break off and go to the lungs and then just completely occlude that blood flow from getting to the lungs. And these patients are essentially suffocating. There's really no amount of resuscitation that they could do, at that point, if it's all a sudden acute event. Some complications of DVT. We can have pulmonary embolism. Another big complication of DVT, we can wind up with venous insufficiency. And this is a result of DVT damaging valves. Can have chronic venous scarring. Chronic venous scarring. Veins appear narrow. With echogenic walls. We also have chronic lower extremity swelling. This could be a result of reflux. Or that chronic venous scarring. Chronic venous scarring. Treatments. The first one is we have anti-coagulation therapy. So with anticoagulation therapy, this prevents new thrombus from forming. I'm just going to put slash does not break down thrombus. Does not. So these medications, they work to prevent new clots from forming, but they're not going to break down the clots that you already have. So it's the body that's going to break these down naturally over time. So these medications include heparin, we put IV heparin, Coumadin, Lovenox, here they have Xarelto, what are the ones? Heparin. I'm spelling that wrong. Heparin. Coumadin, Lovenox, Xarelto. Those are the big ones. Another treatment, we can have thrombolysis. So this is medication to dissolve or break up clot. break up thrombus. So this is an invasive procedure. Medication is inserted with catheter directly into affected veins. This is used only in severe cases of DVT. Another potential treatment could be an IVC filter. So this catches and prevents thrombus from going to lungs. The IVC filter is, again, this is an invasive procedure. Filter is placed below level of renal veins. So the reason they do this is they also want to try and protect the kidneys as well. So they don't want any thrombus to potentially go up the IVC and start invading the renal veins. And now you wind up with renal issues and kidney issues on top of your DVT. The big example of this is a greenfield filter. That might be the common name that you hear. Greenfield filter. So these filters you can actually see on ultrasound if you're scanning the IVC. So you may all of a sudden be doing like an abdominal study, and this patient's had a history of DVT, you know, maybe like 10 years ago or whatever. They don't necessarily take these out, you know, unless they become an issue, you know, if there's an issue with them either moving or potentially puncturing like the vessel, or you wind up with like a leak or something. But they typically stay within the patient, you know, once they place them. So you can potentially see this when you're doing an abdominal study. And if I'm kind of imaging my IVC, I might see something that it'll look echogenic, kind of almost like this within the IVC. You can be like, huh, what's that? You know?
You may encounter on beds for down, but
So I know some of you were asking, you know, like, what's the DVT going to look like? How would we see one, you know, when we come across an ultrasound? So, I mean, this shows here your common femoral vein. So we know this is the right leg, because this is, if we're in transverse, this is going to be medial. This is going to be towards the patient's right. So we could see DVT is quite obvious. You have your artery over here flashing. And when you compress, this is going to be non-compressible. So this would be an occlusive DVT, you know, within the common femoral vein. If you can imagine, it's going to look pretty similar as you go down the leg. See, they're doing compression here. Again, a little bit of compression up here by the greater saphenous vein, by that junction. But there's obvious thrombus. So this is an acute thrombus within the common femoral vein. It kind of has this like spongy echo texture to it. So as we move down the leg a little bit more, this is now, femoral artery. And this is femoral vein. So over here, it looks like you're getting a little bit of flow around that clot. But again, it's primarily thrombosed. If we show compression, so you can see there's a small area here of the vessel that compresses, but the majority of that vein is now thrombosed. This is another image of a common femoral vein. So this is a femoral vein. This is the greater saphenous, also that's thrombosed. This is that saphenous femoral junction. So the reason this junction is important to image too is because you can have thrombosis within the greater saphenous vein that actually extends into the common femoral. And this is a picture of popliteal vein. Again, doing your compression, you can see it's not compressible, and you can visualize, you see the thrombus within it, this spongy texture. And the darker it is, the more acute it's going to be. So this might have been like, a couple days old where you're starting to get a little bit of whites. It's more heterogeneous. Again, you could see it's non-compressible. So this other vessel here probably is the gastrocnemius vein, which is also thrombosed. For back here in the popliteal. So this other one off to the side. All right. Does anyone have any questions about DVT? DVTs or general vein questions, like before we get into some of the other testing? Venous reflux. And we have venous reflux testing. So we're testing the competency of the valves, and we want to make sure that the valves are competent. We don't want to have incompetent valves. So with venous reflux testing, the main method is use of ultrasound. So with ultrasound, we can do a standing reflex study. So if patient unable to stand, so we'll put them, well, we'll have them lie and lower deep. I'm going to image both deep and superficial veins. As well as perforators. This is perforator. So perforator vein is a connection between superficial and deep systems. Deep veins. This is your perforator in the middle. Over here we have deep, over here we have superficial. The perforator is your connection between the two. So blood flow in the superficial veins crosses over into the deep system through the perforator veins. So that's going to be your normal flow direction. If we're looking at a leg. So blood wants to go back up to the heart. So in these perforator veins, blood's coming up, travels across the perforator vein from the superficial into deep. So blood flow normal is superficial to deep. With incompetent valves. Blood flow goes from deep into superficial. So if we have incompetent perforator veins or valves in the perforator veins, so instead of that normal blood flow, if that valve is now incompetent, blood flow is going to come through the deep veins, through that valve, back into the superficial system. So incompetent perforator veins will lead to varicose veins and varicosities. So now we're going to attempt to induce or cause reflux. So sometimes standing is just enough to do that. So that's why if the patient's able to stand and you are able to exhibit reflux when they're standing, you don't have to, do Valsalva or the compression. But if they're not able to stand, we can have the patient Valsalva. Or we can do proximal compression. See, and with distal compression, so meaning you're squeezing the calf below the level of where you're imaging with distal compression. Reflux can be seen with release, can be seen on release. And reflux time greater than 1 second is considered significant. So then what does it look like on ultrasound? So if we have our normal vessel and we put our color box on, so we'll visualize our normal blood flow is blue. And then when we have them Valsalva, or we do that proximal compression where we're compressing the leg or the vessel above where we're imaging. We should have a change in color. It should then appear red. With Salva or proximal compression. Sometimes you could see this going on without having to do anything at all. So you can tell right away, even if you're just starting your test, you're seeing this happen just normally, you know, those valves are severely incompetent. You don't even have to Valsalva or do anything. You know, they could be lying completely flat. You might be doing a DVT study and you might notice this. So then what is it going to look like on spectral tracing? We'll have our normal venous waveform. We'll have them Valsalva. And then we'll look for venous flow to go above the baseline. And this is your point of Valsalva. Or proximal compression. And then this would be your point of release. So you can have them, you know, relax, you know, stop Valsalving or release compression. So this is release of Valsalva or compression. Compression. So what we're looking at is the amount of time that there was venous reflux. And this is going to be, you know, our time markers here across the bottom. So you'll be able to count how many seconds that was, you know. So I mean, if you're getting, you know, 2-3 seconds, you know, you don't have to have them keep Valsalving. You already know it's severe reflux. So if we're using the distal compression method, it's going to look a little bit different. So we'll have our normal venous waveform. And when we do distal compression, we're basically augmenting. We're doing an augmentation. And then when we release that augmentation, we see reversal of flow and a return back. So this would be your distal compression. And this is the point where you release compression. So we have our normal flow, we do our distal compression or augmentation, we get a surge back, and then when we release that compression, we should get, if their valves are incompetent, we'll get reflux visualized within the vessel. So if it's normal, we shouldn't have that. You can also use Photoplethytography. So I'll be darned if I know how to spell that. Photoplethytography. With this, we're placing PPG sensor. Five to 10 centimeters above medial malleolus. And we're measuring venous refill time. VRT. Normal VRT is greater than 20 seconds. VRT, which is less than 20 seconds. Indicates reflux. So the reason for this is it takes a long time for the veins to refill with blood through the capillary bed system, from getting it from the arteries. So if we have the veins refilling quickly, it's because those valves are incompetent and leaking, so blood flow is returning back to the cap. All right. So with this, we have patient sit. With legs yeah, I'll just put, we have the patient sitting, have patient dorsiflex foot, slash, you're flexing calf muscle, flexing calf muscle to empty venous blood from calf. So you're going to do this about 5 times. Perform. So you have them flex their foot, or flex their calf muscle 5 times, empty out the blood from the calf. You'll get your tracing where you have them flex, 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 flex. And you're looking for your tracing for that venous refill. So that's what your chart is gonna look like. So our values. Actually, before I get into that, so we're going to repeat this step also with, well, we're going to initially do it without a tourniquet. So without tourniquet. And perform with tourniquet above and below knee. And the reason we place the tourniquet is to remove influence of superficial veins.
Dan, can you move that camera like just a little to the right? Like cutting off. Yeah, there you go. Thank you.
Yeah.
Don't erase that yet.
So you place the tourniquet above and below the knee to remove the influence of the superficial veins. So above the knee, you're removing the influence of the greater saphenous vein. When you place it below the knee, you're removing the influence of the small saphenous vein. So values. So VRT. That is greater than 20 seconds. Without tourniquet. That is without tourniquet is normal. / no reflux. So a VRT that's less than 20 seconds with tourniquet above me. Could either mean reflux of deep veins or reflux of small saphenous vein. If you have a VRT of less than 20 seconds with tourniquet both above and below. Me. This is reflux of the deep veins. Alrighty. Okay, you guys can see that. So with this study, we're going to place our sensor, just above the ankle, about 5 centimeters above the ankle. We're going to get our tracing. So we want to see long refill times. That's going to indicate, that there's no insufficiency going on. So if we place our tourniquet above the knee here, we're now removing the influence of the greater saphenous vein. So removes influence of GSV. So once we remove that influence of the GSV, if our VRT now goes back to normal, which is greater than 20. Then reflux is from the greater saphenous. So we do our initial baseline and we got a very fast refill time. We had no tourniquet on. We saw a very fast refill time. That's our first indication. All right, this patient has reflux. So when we move on to the next step, we place the tourniquet above the knee. We compress the greater saphenous vein, and we have a return back to normal for our venous refill time. We can then, deduce from that the reflux was coming from that greater saphenous vein, because now the lesser saphenous vein, is normal, as well as the deep system. We're not picking up any reflux now in the cap once we close off that greater saphenous vein. But if we still have a venous refill time, that's very fast, that's less than 20 seconds. We then place our cuff here, or our tourniquet here, below the level of the knee. So you can see this blue one is your greater saphenous, the purple here is your lesser saphenous, and this white one is your deep veins. So if we have a venous refill time that's less than 20 seconds when we place the one above the knee, the reflux could be coming from the deep or it could be coming from that lesser saphenous. So we have to investigate further. So we place the cuff or the tourniquet or the cuff below the knee. And now we're compressing both the greater saphenous and the lesser saphenous veins. This removes influence both GSV and small saphenous. If VRT is now greater than 20. So if we return back to a normal VRT after we place the cuff here now, then reflux is from small saphenous vein. If you think about it, we put the cuff here, we're still getting reflux. Could be one of those two, the small saphenous or the deep system. We move on to the next step, we put the cuff here, we're still getting reflux. We've eliminated those two vessels. We know it's coming from the deep vein. But if we get a return back to normal with the cuff here, so if it was abnormal here and then returns to normal here, then the reflux is from the small saphenous vein. But if still abnormal, so BRT, less than 20, reflux, deep vein. Let's do respiration. Flow. Inspiration. Increases increases abdominal pressure. Abdominal pressure. Decreases thoracic pressure. If we increase abdominal pressure, we're going to decrease lower extremity flow. Increase upper extremity. Sorry, I should have put that down there. But we have lower pressure up here, so things want to go from high to low, so we're lowering the pressure. In the thoracic cavity, you're going to increase blood flow in the arms, and you're increasing your abdominal pressure, so you have a high pressure now in the abdomen, you're going to decrease the flow in the legs. And then, you know, expiration is opposite. patients, I'll have a decrease abdomen pressure, increase thoracic pressure. This is a decrease flow in arms, increase flow. And Valsalva. Increases both abdominal and thoracic pressure. So we'll have a slowing or stopping of blood flow. In both upper and lower. Extremities. Valsalva will also cause veins to dilate. Will cause veins to dilate. So, other venous testing. We have contrast Vinography. So with this, we inject dye into vein and use serial X-ray images to trace or track contrast as it moves through vessel. dye. You can also put contrast. We have two types of contrast venography. We have ascending and descending. So ascending venography. This is used to evaluate for DVT. Or DVT. So we're going to inject in dorsum of foot. So we're going to inject the contrast into a small vein in the dorsum of the foot, and they're going to image the contrast as it works its way back up the leg. And they're going to take images as it works its way back up the leg, and they're going to look for any filling defects or any vessels that don't fill with contrast. And that's how they're able to determine if there's clot or thrombus within those veins. So they're going to look for vessels which don't fill with contrast. You can do the same thing for the arms as well. You just go in the distal arm, you know, maybe the top of the hand, the dorsum of the hand now. Inject the contrast and track it through the vessels of the arms as well. So this is ascending venography because the contrast, I think, is ascending, it's going up. And then the other one we have is descending venography. With descending venography, this is used to evaluate for insufficiency and reflux. That's for efficiency. So I tried to make this leg look a little bit bigger. So this is the more swollen leg. This is the side that they're concerned about, say the right. So with descending venography, they're actually going to inject the contrast, or they're going to go in with a catheter into the other side of the groin, up here at the level of the common femoral vein. And they're actually going to run their catheter up the iliac into the IVC and then back down the other iliac, and then release the contrast into the common femoral vein on the other side. So they'll enter contralateral say groin. Terminal vein. And run catheter up iliac, and then down to opposite common femoral vein and release contrast. So when they release the contrast up here in the common femoral vein, they're going to watch it as it works its way back down the leg. And that's how they assess for reflux. So if they release the contrast and they don't get any contrast coming back down the leg, there's no reflux. So descending, the way I remember again, now the contrast is descending, it's going down. And then assessing for PE, pulmonary embolism. Gold standard now is CT pulmonary angiogram. So this is a CT with contrast to evaluate pulmonary vessels. So this is similar to that ascending venography. We're going to be looking for vessels which don't fill or partially fill with contrast, partially fill with contrast. So this is very accurate for determining or evaluating for pulmonary embolism. The other test we have is a VQ scan, which is a nuclear medicine scan. We have our VQ scan. So this contains two parts. You have a ventilation. And perfusion. So under the ventilation part of the test, patient inhales the radio isotope. And we are able to visualize how lung fills with oxygen. So with that, we're visualizing, how the alveoli are working, those little air sacs, if they're able to fill. And if there's damage to those air sacs. Then the perfusion portion, isotope is injected. So injected. And we evaluate vasculature. So with this portion, we're evaluating the blood perfusion to the lungs. Slash blood perfusion. Of lungs. So with this test, they put those two components together and they determined how likely it is that the patient has a pulmonary embolism. So this test is graded as, not likely, likely, or highly, I'm sorry, I'm gonna say no evidence, low probability, medium probability and high probability. But unfortunately with this, other things can mimic, the presence of pulmonary embolism. So patients that have COPD, asthma, other lung diseases. Can give false positive. And so we're going to go into vein mapping. So the point of vein mapping, we do vein mappings for. So the point of vein mapping, we're going to harvest a superficial vein. Or use as an arterial bypass. So for an arterial bypass, that could be coronary, so in the heart. Coronary bypass. Or it could also be in the extremities. Typically lower. Or it could also be used for a hemodialysis access graft. Hemodialysis. Fistula. Slash graft. Important to remember, we're just looking at the superficial veins for harvest. We're not going to harvest a deep vein. And the other thing too, we don't bypass clots in the veins. Clots in the veins, we treat them with medication, the body breaks them down on their own. So we're just bypassing arteries. Measurements. With our vein mapping studies, we always assess for the presence of DVT. So we're going to do a deep vein study as well, make sure there's no clot in the deep veins. We're going to make sure there's no thrombus in the superficial veins, so no thrombophlebitis. And then we go back and we take our measurements. Measurements, diameter. No veins. Need a diameter of greater than 0.3 centimeters, 3 millimeters. So is that 0.3 or 3 millimeters? That's for AVF, AV fistula, or bypass, arterial bypass, or arterial bypass. Vein diameter of greater than or equal to 4 millimeters. 0.4 centimeters. That's for use with an AVG, an arterial venous graft. So those are the synthetic grafts. And then if we're doing the Allen's test and we're looking at the radial artery, so we need also a radial artery diameter of greater than 0.2 centimeters / 2 millimeters. So this is for use in either AVF, AVG, or harvest, or coronary bypass. All right. Yeah. These are arterial venous fistulas that we use for hemodialysis. Most common is a radial to cephalic, radial to cephalic. You can also have radial to basilic. Brachial to cephalic. Brachial to basilic. This brachial to basilic is oftentimes called the basilic transposition. Transposition. So we always try and use the non-dominant arm. Try and use non-dominant arm. So all these graphs here, these are called autogeneous graphs. Another name could be, it's Brassica semino. I'm going to spell it as Brescia. Semino, Cimino. Brassica semino fistula. Another term you see on your registry. So autogeneous means they're natural, they're part of our body. And then we also have synthetic grafts. Grafts. So these are our loop grafts. Straight grafts. These can be made of vortex. Or PTFE. So this is poly, tetra, fluoro. Ethylene. Another material they can also use is Dacron. Right, so trying to think what else. I'm going to put Doppler changes. It's important for us to recognize Doppler changes in vessels. With AVF, G. So first major change is artery. Proximal to anastomosis. Becomes low resistance and high velocity. So you're gonna have very fast velocities, like I just put 400. I mean, I'm just making up a number. So you're gonna have high velocities and you're gonna have a large diastolic component. So when we're Dopplering the arms and the legs, our normal blood flow should be triphasic. So we should have, should be very low, very high resistance because it's going to the capillary beds. But when we have an AVF or an AVG, the first thing we notice in those arteries is we get increased velocities and it becomes lower resistance. So we have a large diastolic component. The reason for this is now we have a connection between two different pressure systems. So then at anastomosis, or that connection between the artery and vein, we're going to wind up with our fastest velocities. And the blood flow is also going to be very turbulent. So we're going to get filling of that spectral window. You're going to get spectral broadening. So at anastomosis, you'll have your highest velocities. With turbulent flow. So venous now that we are entering the veins, so now we have arterial blood flow entering the venous system. So now we're going to notice with our venous blood flow, we're going to have increased velocities. We'll have velocities, like 100, 200 potentially, within that vein. And we're also going to notice now pulsatility to it. So it's going to kind of almost take on some arterial features. So this is now referred to as a mixed signal, mixed venous signal. We're now getting some pulsatility from that arterial blood that's mixed in with the venous thing. So we're going to have high velocities, high velocity. With mixed venous signals. It's going to be pulsatile. You're going to have pulsatility to it. It'll look different from respiratory variation because respiratory variation, it's not going to be uniform. So with these mixed signals, you're now getting, it's almost essential like a rhythm, like your heartbeat. So it's going to be, even spacing between your points. I mean, you can always have the patient, take a deep breath in, hold their breath, Valsalva, and see if you get any changes. So if you don't get any changes, you'll know that it's that arterial influence. But the main takeaway is you're going to see increased velocities. And the veins will also dilate. Veins become dilated. And just real quick, distal, or I'm gonna say artery distal. Anastomosis. Will return to high resistance. And may sometimes demonstrate retrograde or opposite direction, retrograde / opposite direction flow. So this would be a Steele syndrome. And then, depending on severity of symptoms, intervention might be needed to correct Steele syndrome. To correct Steele. Okay, so any quick questions before I open up that quiz? So it's just I posted just a quick 5-question bonus quiz that we're gonna add on to your lowest test grade. So I'll open it up to everyone. There we go. All right, so it's opened up. If you guys want, you can go ahead and log on and do it. You guys can just let me know if anyone still needs more time or if you're still.
I do. I'm still thinking about 2 questions.
Okay, no worries. No problem.
Can you go over these answers too when we're done?
Yeah, sure. Does anyone need more time? Is everyone good? I'm sorry? Screenshot. All right, so from quiz 2. So all our reasons for performing a venous mapping except. So a lot of people put for potential arterial bypass of a lower extremity artery. So we do a vein mapping to potentially bypass an occluded artery. So we're going to look at the greater saphenous vein, particularly the greater saphenous vein. We'll do a vein mapping, and they could potentially remove that greater saphenous vein to use it as a bypass to bypass an occluded artery to get perfusion down to the foot, or bypass, if there's a segment in the thigh that's occluded, they'll bypass the segment in the thigh that's occluded. We do a vein mapping, for potential arterial venous fistula for hemodialysis. We also do vein mappings. We assess particularly, the greater saphenous vein for coronary artery bypass. So the only thing that we don't do a venous mapping for is to occlude for occluded lower extremity vein, deep vein. So we don't bypass veins. So that's the correct answer. All of the following are superficial veins whose diameter, bad English, are measured as part of a vein mapping except. So the correct answer is ulnar vein. That's a deep vein. So we don't measure the deep veins. We only measure superficial veins. We'll measure the greater saphenous for a lower extremity vein mapping. We'll also measure the small saphenous as part of a lower extremity vein mapping. And then we'll measure the cephalic and basilic veins in the upper arm. As part of a superficial vein mapping, we must also evaluate for the presence of deep vein thrombosis. So this is true. Part of every vein mapping study, we're also assessing for DVT. Particularly if we're using it for an AVF or a fistula. Like, we need to know if there's clot in those deep veins, because we're going to create a fistula that's going to eventually drain into those deep veins. And that's going to severely affect our fistula. So when performing a vein mapping, in order for a superficial vein to be considered acceptable for use, it must have a diameter of 0.3 centimeters or greater. I know in some of our slides it says 0.25, but for me 0.25, essentially rounds up to 0.3. So 0.2 would be too small. So if it's just 0.2, that would be too small. So you need to have over that 0.25 or 0.3. And if we're using it for to attach for a graft, then it would have to be greater than 0.4. So all these are too small. So this would be too small, that'd be too small, that'd be too small. An artery in the upper extremity, which artery is evaluated in the upper extremity is evaluated and its diameter is measured as part of a modified Allen's test. So that's the radial artery that we look at. And the test is in order to determine if there's an intact palmar arch. So we won't take that artery unless that palmar arch is intact. Diagnosis of a complete palmar arch can be made if the correct answer is radial artery flow will increase when we compress the ulnar artery. So the reason it increases is because the hand now needs more blood flow to compensate for that radial artery that's being compressed. So we're going to see an increase in flow to feed the rest of the hand. That increase of flow goes through the palmar arch to feed the rest of the hand. So we see an increase in that arterial flow. And then conversely, if we compress that radial artery proximal or above where we're imaging, we're going to see a reversal in that flow because we're not creating a Steele syndrome. So that hand still needs blood flow. So it's going to reverse the flow in that palmar arch. And we'll see a reversal of flow in that distal radial artery that we're seeing in order to feed the rest of the hand. So if we compress above where we're imaging, we're going to see a reversal of flow. In a reflex study, the examiner images the popliteal vein and notes that the venous color flow display lights up blue with calf compression. So that's our normal augmentation. So we get that normal flow direction. And then red for 2 to 3 seconds on release. So this is that other method of doing a reflex study where we do distal compression. So we're imaging the popliteal vein. We're doing distal compression, compressing the calf. So we'll see a normal augmentation with compression, and then with release, we see reflux at 2 to 3 seconds of reversal flow, that red color upon release. So this is just venous reflux. So the Valsalva maneuver slows down or stops blood flow in both the upper and lower extremities because we're increasing pressure in both the upper and lower extremities. We'll also see dilatation of the vein. So when performing venous plethysmography exam, a venous refill time greater than 20 seconds without the use of a tourniquet indicates absence of venous insufficiency. So greater than 20 seconds is a normal refill time. And we're not using any tourniquets. So that means that there's no insufficiency present. So a venous refill time. I have bad wording. Venous refill times with plethysmography was 10 seconds without a tourniquet and 25 seconds with a tourniquet above the knee. Diagnosis is so if it returned back to normal with a tourniquet above the knee, it's definitely not superficial vein thrombosis, but then this isn't ruling out DVT. It can't be a deep vein because we can't use a tourniquet to, block the influence of the deep veins. So it can't be that one. It can't be that one. It's not for DVT, or I'm sorry, superficial vein thrombosis. So it's not for assessing clots. So the only choice left would be a greater saphenous vein insufficiency. Descending venography is performed to diagnose valvular insufficiency. Ascending venography is to evaluate for clots or thrombus. So the puncture site for introducing contrast in venography to assess for deep vein thrombosis is done at what level? That's the common femoral vein level. Dorsum of the foot would be for a ascending venography. I'm sorry. So this would, oh God, I get confused. So common femoral vein level for B for descending venography. I apologize. And then the dorsum of the foot would be for ascending venography. So for DBT, it's ascending venography. So we want to introduce the contrast low and watch it travel up the leg. This is good. Elevated, everyone got this one right. Elevated D-dimer could potentially indicate presence of a thrombolytic event. So the direction of blood flow in an AVF is from a higher pressure artery into a lower pressure vein. So arteries are higher pressure. The blood flow is going to go from that artery into the venous system. Which best describes the flow characteristics of an artery just proximal to the anastomosis with the vein. So just above that connection, the artery is going to have high velocity, low resistance. So there's decreased resistance and increased velocities. The minimal diameter for an artery in order to be used for an AVF or graft is 0.2 centimeters. Vessels that are commonly connected to an AVF or commonly connected to create an AVF include all of the following except. So radial artery and cephalic vein, that's probably the most common that we like to use. You can also use brachial artery and cephalic vein. You can use brachial artery and basilic vein. And the reason we don't use the cephalic subclavian artery and cephalic vein is if we think about where the subclavian vein, subclavian artery and the cephalic vein are up in the chest. Like you really have a short segment of that cephalic vein that you could utilize as your fistula. So it's really not, doesn't make sense to try and connect those two. Whereas when we're connecting these other vessels, we have a large segment of vessel that we can access, a large segment of vein that they could use for doing their dialysis. An isotope test for pulmonary embolism that involves breathing and injecting of isotope and reported as high, medium, or low probability of pulmonary embolism is called a Rpq scan. When assessing an AVF, a palpable thrill can be felt at. So this is at the anastomosis of the artery and vein. So we feel that thrill right at that connection. That's where you're going to get your fastest velocities and your most turbulent flow. So that's basically what you're feeling is that turbulent high velocity flow. This is a common phenomena seen in the artery immediately distal to an AVF or AVG. So immediately distal to that anastomosis, we can potentially see a Steele syndrome. Good. So everyone got that right. So in sagittal view, color Doppler imaging shows flow within the greater saphenous vein as blue. During Valsalva maneuver, venous flow is displayed as red. So this signifies valvular incompetence or reflux. So we have normal flow direction as blue when we're imaging. We Valsalva, we see venous flow displayed as red. So that indicates direct change in flow direction, so that signifies valvular incompetence. So when Photoplethytography is used to evaluate venous insufficiency, the criteria for determining incompetence of the greater saphenous vein is, so we have, for greater saphenous vein, we have a venous reflux time of less than 20 seconds without the tourniquet. And then when we place the tourniquet below the knee, we have a venous reflux time that is greater than 20 seconds. And we also have a green venous reflux time that's greater than 20 seconds when the tourniquet is above the knee. So we've eliminated, you know, the lesser saphenous vein by doing this, as well as, you know, when we're up here, we eliminate the greater saphenous vein. So if the venous reflux time below the knee, I'm sorry, this one below the knee was less than 20 seconds, it could potentially be the lesser saphenous vein or the deep veins. So venous refill time of less than 20 seconds with and without a tourniquet. So the entire test, we're getting, you know, fast venous refill times. That would be a deep veins, deep venous insufficiency. So this one would be a venous refill time without a tourniquet is abnormal. And then below the knee is normal, but above the knee is abnormal. So this would be a lesser saphenous vein reflux. So the best position for performing an ultrasound for venous reflux is standing. So if we're able to get them standing, that's the best position. It puts the most pressure on the valves and mimics, you know, real life scenarios when patients are up and walking. So if they're not able to, you know, do standing, we'll put them supine and lower the legs. We definitely don't do prone, and we definitely don't elevate the lower extremities. Percentage of blood stored in the venous system, it's between 60 and 70%. So about 2/3 of our blood is in the venous system. So then complications of deep vein thrombosis include all of the following except. So a complication for sure is pulmonary embolus. We can wind up with valvular incompetence. You know, DVTs can damage those valves. Patients can wind up with chronic lower extremity swelling. So the only one that, you know, isn't a complication would be congestive heart failure. Any questions for anyone before I let you go? Thank you for staying on late. I apologize for keeping you.
Thank you.
No, I thank you. I wanted to
Thank
stay
you.
on because I needed help
No worries.
to make sure, you know, what I got wrong.
Alrighty.
Have a good one.
Yeah, thank you. So.
Thank you.
Bye. Thanks.
All right, thank you.
Bye.
Thank you.